Welcome. My name is Sarah Holtman, and in this micro session, we'll review the Wound Healing Cascade, a coordinated, overlapping series of events that restores tissue integrity. We'll cover the four classic phases, the principal cell types and signaling molecules, why wounds stall, and how this informs day to day wound care. These phases are not discrete boxes, they overlap, and the quality of each phase strongly influences what comes next. Hemostasis starts immediately after injury. Vessels constrict to limit blood loss, while platelets adhere to exposed collagen, forming a temporary plug. Activation of the coagulation cascade stabilizes this plug into a fibrin clot. That clot is biologically active. It traps cells, stores growth factors like PDGF and TGFV, and forms a provisional matrix for incoming inflammatory and reparative cells. Efficient hemostasis sets the stage for orderly healing. Prolonged bleeding or anticoagulation can delay everything downstream. As hemostasis stabilizes, inflammatory cells flood the site. Neutrophils arrive first to phagocytose bacteria and debris, releasing proteases and reactive oxygen species that must later be downregulated. Monocytes mature into macrophages. Early M1-like macrophages continue cleanup and defense, then transition toward M2-like phenotypes that secrete pro-repair mediators. Key cytokines IL-1, IL-6, TNFA coordinate vascular permeability and recruitment. Balance is essential. Too little inflammation invites infection, too much or too long stalls healing. During proliferation, the wound builds new tissue. Endothelial cells sprout new capillaries under VGF signaling, creating granulation tissue that supplies oxygen and nutrients. Fibroblasts proliferate and deposit extracellular matrix, initially collagen 3, providing tensile strength. Keratinocytes migrate from wound edges and appendages to re-epithelialize the surface, while myofibroblasts contract the wound. Moisture balance, offloading, and infection control are critical here to support orderly cell migration and matrix assembly. Remodeling reorganizes tissue for function. Collagen 3 is gradually replaced by stronger collagen 1, with increasing cross-linking and fiber alignment along lines of stress. Excess capillaries regress, so the scar blanches. Matrix metalloproteinases, MMPs, and their inhibitors, TIMPs, rebalance turnover. Even after months, repaired skin reaches only about 80% of original tensile strength, so prevention of re-injury and continued offloading remain important. The cascade is steered by a dense signaling network. PDGF recruits fibroblasts and smooth muscle cells. TGFV promotes matrix synthesis and modulates inflammation. VEGF drives angiogenesis. FGFs and EGF support proliferation and epithelial migration. MMPs remodel extracellular matrix, while TIMPs restrain MMP activity. Who is present, in what amounts, and for how long determines whether a wound progresses or stalls. Chronic wounds are often stuck in inflammation. Proteases and MMPs outpace TIMPs, degrading growth factors and matrix. Local barriers, ischemia, pressure or shear, edema, lymphatic overload, and biofilm sustain inflammation and block migration. Systemic barriers such as protein-calorie malnutrition, micronutrient deficits, poor glycemic control, steroids, or immunosuppression further impair responses. Effective plans target and remove these barriers while reestablishing a pro-healing microenvironment. Translate biology to bedside. Debridement removes senescent cells, biofilm, and necrotic burden, resetting toward acute physiology. Dressing should maintain moisture and thermal stability and protect the peri-wound. Address macro issues, restore perfusion when possible, offload high-pressure zones, use compression for venous disease, control edema, optimize protein and micronutrients, and manage glucose. Align each order with the phase, either remove barriers or support the next step in the cascade. Use this as a pacing guide. Hemostasis is immediate. Inflammation dominates early. Proliferation builds tissue over days to weeks. Remodeling refines structure over months. Overlap is normal. If the clinical picture doesn't match the expected timing, look for barriers. This has been Wound Care After Dark. Beyond the bandages episode on the wound healing cascade, we hope that you'll join us for our next micro session